either they raise your hand or put in chat box and we'll get it discussed. Yes, Kunal, you can
Yes, sir.
share your screen here. So Dr. Kunal is from Panipat, Haryana, and Dr. Vaibhav is from Noida, Delhi. They are our current fellows, and they have worked hard to make these cases presentable. Yeah, please, Kunal, go ahead.
Good morning, everyone. Today's first case I would like to start with. There is a 3 years old female who presented with a painless lurching gait with the apparent shortening of the left leg. And as we can see from the x-rays, there is a left hip dislocation, and it's according to Tonus grade 3 and IHDA also grade 3.
So, Sandip, now looking at this X-ray, what first thing you would like to inquire with the family? Now, this family is from little far place from Ahmedabad, and they saw the child walking with a limp, but none of the pediatrician uh, bothered to take an X-ray or an ultrasound, and this happens. This used to happen quite frequently in our practice. So, anything else you would like to inquire in history, or it looks like a typical DDH to you?
Uh, if I can,
Yeah, ma'am.
is it okay if I say something?
Yeah, yeah.
See, whenever you see DDH, I think we should not forget that there's a whole patient attached to the DDH just because we're seeing X-rays.
Yeah.
We need to actually inquire on, first of all, whether it's an isolated deformities.
Yes.
We often see sometimes the DDH may be not treated because there are a lot of other deformities like recurvatum of the knees,
Yeah.
the bilateral club feet may be there, or sometimes even the upper limb deformities. So it will be good to know whether there are any other deformities. And also, always, though you can here see some of the spine, I have seen patients coming with limb, hip involvement, and you just turn the
Discologenesis,
patient round and there are
spina
features.
bifida.
Yeah, and sometimes lipomyeloneuroseals will be there and very obvious swelling. And this happened to me very recently also.
Yeah.
Patient comes, in a quick doing a camp or something. You see the child with all the hip dislocation, everything. You turn the baby around and they're swelling at the back, and nobody even bothers to mention it. So it's
Right.
important to get other features examined. And if there is a DDH, there are two other things one must ask in the history. One is, without doubt, you should ask what happened in the neonatal period. Did they have a history of neonatal sepsis? So you should make sure that it is not actually a post-septic dislocation, because
Right.
that again can happen. And then look also, just to be on the safe side, at the other physes in the body, like such as knee, around the knee, because that will give you an idea whether this could possibly have been a septic dislocation. Arthrogrypus is another thing that you need to rule out by looking at the other joints as well as contracture. And not to miss this, you should always look for hyperlaxity on these children. And
That's
even though the hip is smaller here and the head is smaller, you must make sure that this patient has not undergone treatment with Pavlik harness, because for neglected DDH never have AVN, but
hmm.
post-Pavlik harness disease may be there if patient has been treated with either a spica or a Pavlik harness before. So that history again is important.
All right. So, such a nice overview, and all the points are well taken. Now, Sandeep, looking at the X-ray, how we can judge that this could be a pure DDH or it could be a post-septic? I mean, just if you bring that out for the fellows, how would you read this X-ray? Kind of?
Looking at this X-ray, my first impression would be a DDH. But of course, all the points that Madam mentioned, they have to be, elicited in the history. And of course, you have to ask for NICU admission. On this particular X-ray, what I can see is what I would look at is, the femoral head shape and the size. So here, obviously, the femoral head ossific nucleus is smaller as compared to the other side, but it is regular. And that leads me to believe that this is most probably a DDH rather than a post-septic dislocation, because in post-septic dislocation, additionally, I would expect to see some fragmentation. I would expect to see some growth disturbances, things like that. So to me, this, preliminary looks like a DDH, except if on history I get some, history of, postnatal sepsis or some swelling around the hip in the neonatal period. So
Right.
my first diagnosis here would be a DDH.
And many a times the DDH is, most of the times we see acetabular dysplasia, while in septic dislocations, if it happened later on, then the acetabular index would be almost normal.
Agree.
Now, yeah, so this,
Having
unlike
said
other,
that, here the acetabulum
it
index
looks
is not
okay.
too bad,
Yeah,
looks good
yeah,
here.
yeah. Yeah, but she didn't have any NICU admission. That way, she was uh, she was not admitted. There was no major illness. And surprisingly, this hip for a neglected one is not that high riding,
Not high value. Exactly.
So, and that is the reason that they have minimal shortening. And so neither parents nor doctors, and some of them are very high riding, which attracts the attention very quickly. And what else you see on X-ray? Do you think there's a pseudoacetabulum forming just on the outer margin, Sandeep?
Yeah, it is just about forming over there. You can use a pointer and just see where the head is abutting against the superior rim of the
Yeah.
acetabulum. Pseudoacetabulum is just beginning to form. Yeah, that's right. That's right. Yeah.
So, Risha ma'am, what is your treatment protocol at 3 years? Uh, would you suggest family that this child would need a combined procedure or anterolateral open reduction only, or can you tell us what is your protocol?
So at 3 years, it is a stepwise. I would go ahead with everything that is required unless the findings in the operation theater indicate otherwise. So plan will be to do uh, I have actually at times now here the acetabulum is quite normal, and I've had at times even a 5-year-old like this where the hip actually has gone inside just in the ward itself while we were examining, and then
Right,
it stayed inside and with just a spica and with no subsequent consequences. So that's a very very rare thing. It doesn't
right,
happen and we don't usually even attempt it, but this
right.
can be there because this is not a very high riding hip. It's just actually standing outside maybe about a centimeter
Yeah,
higher than it should be. So that is something to keep in mind. I'm not saying that we ever do it, but
yeah. So
that
you
is
mean
something to
close it?
keep in
So even
mind.
you should try close reduction. So once you do adductor
N-
tenotomy, then try if it jumps in.
No, no, I actually wouldn't do the tenotomy. I'll just examine it. And after
Okay,
examination, I'll proceed to open reduction. I won't do the
okay,
tenotomy in a 3-year-old. I
Yeah.
would
3 years is
proceed
a
to,
bit high, bit too high.
yeah. So I'll
yeah,
just straight away go ahead for an open reduction.
okay,
At that time, because it looks high, I will actually assess the tightness of the reduction and most likely a femoral shortening, a derotation, since the neck is quite, the varus is quite okay. And so
hmm,
if derotation, if it is required, may not require a varus
hmm,
and will require a estabuloplasty if you think there is an inadequate anterior coverage. So I will do all three at the same time. At 3 years, I don't hesitate because I find that in the series that I've done over the years, whichever component you leave out, you'll end up having to go back for it. Femoral shortening, you definitely never leave out because that's a definite way of getting your 30% AVN or whatever it is that you're going to get if you don't do the femoral shortening. And estabuloplasty is something that you tend not to do if it looks okay, if it looks stable reduction. But if there is an anterior lack of coverage in in this particular case, I would go ahead because at 3 years I don't want to, especially in Indian circumstances, I don't want to have to come back to do it again.
so
Madam,
now,
And it
femoral
does
shortening
happen
is
that
a
the chances of a secondary procedure are very high in a 3-year-old if you leave it out at this stage.
Madam,
yeah,
femoral shortening is a decision you would take on table depending upon after you
Yeah,
open the case. Yeah.
I tell the patients always this that it's a stepwise thing. We do the open reduction. I don't ever rule out a close reduction also, but usually hardly ever in a 3-year-old that you would do a like maybe 1% once in a lifetime, or 2-3 times in a lifetime it may go in. But otherwise, I always say open reduction followed by, if that is requires a femoral osteotomy, most likely it does. Femoral derotation osteotomy plus minus varus here. Or in almost all cases, plus minus varus. The varus is not a big varus for DDH. It's just about some 20-degree varus or something like that. And 15-20 degree varus, if at all you're doing it. And uh, and then follow it by the estabuloplasty. If I think that the head has got a little avian-like look already, or there is a growth disturbance, then I do actually, those are the cases where I will increase the varus, because otherwise within few years you're back to deciding either to do a varus at that stage, or you will land up having to put screws so that the head will not go out. So if avian is looking likely on the x-ray, or if there's a growth disturbance like you see here, in that condition, I think one should go ahead and actually put a little varus, because all of these hips will straighten out. Even if you put a 30-degree varus, it will straighten out. But if you didn't put the varus, in 2-3 years, you'll be trying to decide whether to do the medial screw
Epiphysiodesis.
epiphysiodesis, or whether you're going to do a varus to prevent the head, because there is an eccentric growth disturbance. So that is a preventive step. It's not essential for the reduction, but it is a preventive step for the future.
So now let's fragment this discussion for the understanding of fellows. So first step is to, Kunal, go back to that slide, please. So first step is to you do open reduction, right? And if we are not able to bring the hip in very gently, then you would add femoral shortening, right, ma'am?
Yes.
And once you do femoral shortening, you fixed it, then what is the intraoperative parameter you want to do an acetabuloeplasty? How
So
much of femoral head
before
cartilage?
we do the
Yeah.
femoral shortening, when I'm doing before I go in for femoral shortening, I'll always put my guide wire to get the neck version, so that I
Right.
can immediately see how much antiversion there is. So if there is an excessive antiversion, you have to do the rotation with the femoral shortening. Now, how much shortening to do is again
Is
important. I think
intraoperative.
they should know. Preoperatively, you can assess by how much from the triradiate cartilage, how much is the top of the head. So you can actually make a guesstimate then itself and do it accordingly. You don't actually have to measure and try to do it. But the classical way described is that you do the femoral shortening, see the overlap of the reduced
Oh,
head on the femur, and then excise. But I
mm,
usually, if I'm doing the femoral shortening, I go by the estimate of how much overriding it is doing above the, what do you call it, triradiate cartilage, and take that as the amount of shortening to be done. Now, coming to the estabuloplasty, you look at the coverage, anterolateral coverage, and if you find that it is usually little bit of the head will peep out of the anterolateral area. But if it feels stable, and I also examine it in the reduced position, it says one is uncovering, and secondly, you just see the stability of the hip, because in hip, the stability should not be after you finish doing the uh, repair. Hip should always be bony stable before you decide to close it. It should not have to depend upon your
capsular
capsular
epithelium.
repair.
Absolutely.
So that is when you check it. If you find that the hip is very unstable anteriorly, or you have to put it in a lot of flexion to keep it stable and it keeps popping out, that is definitely a 100% indication for doing estabuloplasty. But at
Right.
3 years, if there is uncovering, you should just go ahead, even if it is stable. If there is uncovering, it's safer, so that you don't have to come back to just go ahead and do the estabuloplasty, so that when your child comes out of the plaster cast, they are fit to walk. You should not have to, in a 3-year-old child, have to put a second set of abduction brace for these children. So if you are going to require an abduction brace, you do your varus. If you're going to have a situation where you need to flex to keep the hip inside, and then you should go ahead and do the estabuloplasty. That's
Right.
my approach.
Yeah. So I work with Dr. John Wedge, it's like is what he used to say, once you put the hip in neutral position and the amount of head cartilage beyond the labrum, you see more than 5 millimeter. That is more 5 millimeter of femoral head would be seen, and that is a usual femoral anteversion. But if more than 5 mm, that means it's more anteverted and you might need to cover anterolaterally. And of course, they used to do Salter osteotomy there. But fine, so this is very important discussion. The decisions about shortening, amount of shortening and acetabuloplasty are intraoperative, and you can forecast based on X-rays. But sometimes you will be surprised, especially in children with hyperlaxity. But here the child was not hyperlax, and our decision is based on Catterall's criteria. What we do, the intraoperative test of stability, it is the refined version of what Vrishra ma'am told from experience. Yeah, Kunal, move ahead.
Could I just make a comment about the hyperlaxities, since we may not come back to the discussion about hyperlaxity again?
We have a case, ma'am, so we'll
Okay,
come
fine.
to that. Yeah, yeah,
Uh,
Kunal.
According to this paper by Cattrall sir, we assess the stability intraoperatively, as sir and ma'am has rightly explained. When we intraoperatively assessed the stability, we were found that the patient was stable in neutral position. As according to this paper, we require no additional osteotomy. And so we did only a anterolateral open reduction with capsulorrhaphy.
So this test of stability is done without capsulorrhaphy. If your hip reduces in, and then you check that if it is stable in neutral position, then you don't add anything. If it needs internal rotation and abduction, then you might need a derotation and subtle virus. If it is stable in flexion, then as ma'am says, then you need to provide anterior coverage, and internal rotation, flexion and abduction, then you combine. So this was the paper, and we take this paper in account. And this patient, and this is a nice paper for all the fellows to read, the test of stability by from England. And in this case, it was stable, so we just did the capsulorrhaphy. And this is usually at this age we need a combined procedure, but in this case it was a little different. Now we were very observant that isolated anterolateral open reduction would it lead to a normal acetabular development in future, because we are worried about acetabular index to improve. So in Sandip, in your practice, when you would add a acetabular procedure,
So,
uh, yeah.
So, in the initial part of my practice, I was a bit selective in doing my, pelvic procedures. But, in the last about, say, 5 or 6 years, we have been doing it in almost every case above the age of 18 months, where the acetabular index has been, more than, 30 preoperative. So, in those cases, even before we open the hip or we assess the stability at the end of an open reduction, we had decided that we are going to do an acetabuloplasty in all children above the age of 18 months with AI more than 30 degrees. And apart from that, the intraoperative test of stability, as you have mentioned, if there is the hip is staying stable only in flexion, and the moment you extend the hip, if it is coming out, that is the other indication where we would, add in an acetabuloplasty. But we are quite aggressive, quite, in all children over the age of 18 months, almost all of our kids do need acetabuloplasty if the AI is more than 30.
Yeah. So
There
our
is the case
observation,
like
we
yours is an
yeah,
exception, where
Yeah.
the acetabular index is good even at 3 years of age, and the hip is stable in drop. That is an exception where you may omit.
so yeah, so this was a protocol we used to follow at Sick Kids also.
Yeah.
But let's and later I studied our data, and we found little different. But let's move on to this case. We have 4 cases, so Kunal, let's go ahead.
Yes, sir. The postoperative X-ray was like this. The spica was given for 2 months, and then it was removed, and patient was followed every 2 monthly. We can see the third X-ray shows the acetabular index from the non-pathological side was only 20 degrees, while the pathological side was 28 degrees. The next follow-up X-ray was taken at 1 year, and the acetabular index was 30 degrees of the left side. and it was decreasing, but it decreased till 3 years post-op at the age of 6 years.
So there is some signs of AVN, ma'am. What do you think?
Yes, 1 minute.
That have,
Can you just excuse me for a minute? I've
Yes.
got some urgent call about my sister. Just 1 minute. She's
okay,
in a hospital.
no problem.
Just excuse me for 5 minutes.
Yeah, Sandeep.
Yeah, I agree. There are signs of AVN now, and the things that radiologically you have to look for is fragmentation,
Uh,
flattening of the femoral head, widening of the metaphysis. So all these signs are being seen. However,
hmm,
at this point of time, there is nothing,
worrisome. Yeah,
that I would add at this point of time. I would just place him under careful observation.
yeah,
Uh,
and
I don't know whether we are going to discuss this point later, Maureen, but what is the position of your post-operative spica cast? And what is your post-op protocol, after doing an open
yeah.
flexion?
So
We can discuss that for the
we
post-op fellows. Yeah.
yes. So we check the stability in all the positions and do the necessary procedures as ma'am and Sandeep discussed. We tend to apply hip spica in around 30 to 40 degree of hip flexion, 30 degree of abduction, and about 5 to 10 degrees of internal rotation. And it's usually a bilateral hip spica, even for a unilateral DDH. I do not apply a unilateral spica. It's always a bilateral spica with a bar in between because these patients are coming from very far many a times and they play a lot and sometimes they break it. So to give a stability, we put a bar and we have devised the hip spica stroller. No, so this 30 to 40 degree of flexion is for better place them on that spica stroller. So we on day one, the children are upright in the hip spica stroller, and so that is the position we immobilize. The spica, we spend a lot of time for family education about how to take care of spica, and with that advent, we do not need to change the spica. So we keep our spicas for 2 months, and after two, of course, they come at 15 days and a month for a check. But most of the times, the spica condition is good. I mean, we can take a talk on how to take care of spica and how to apply a spica and sometimes. But we have stopped changing the spica for last 10 years. We continue same spica for 2 months, remove it, and put a hip abduction orthosis full time for first 15 days and then at only night time for next 15 days. So for almost 2.5 months, child is in some form of immobilization. Is the same you practice, Sandeep, or
One
some?
important difference is, that we do, and many of the Western authors may find this disagreeable, but we do place a transarticular K wire for a period of 4 weeks, and
Okay.
which has been a routine protocol at Vaidya, and we also know that Dr. Johri has been doing it for several years, and
Yeah.
we have not found any adverse effects in terms of growth disturbance due to the K wire, nor any K wire breakage has been encountered. Regarding the hip spica cast, the position is almost, what you said, 30 degree of abduction, flexion, and just about a slight degree of internal rotation. We apply 1.5 hip spica. And the first spica that we apply, we make it a point to incorporate the ankle and foot in it as well, not, you
Yeah.
know, not it applied above the ankle because we
Above.
believe
Yeah.
that it gives some additional rotational stability.
Right.
So and the knee is in about 20 degrees of flexion 20.
Yeah. So
We change it, we remove the transarticular wire at 4 weeks, except in cases of ligamentous laxity where we keep it for 6 weeks. We change the spica at 6 weeks, and the total period in spica is 3 months.
right. So it's a very interesting fact how to judge the position of knee. I always tell the position of knee flexion is based on hip flexion. So the buttock and the heel pad should be at the same line. So when you put the child on bed, the buttocks are not lifted. So I think there are a lot of technical intricacies, and we must talk about this because that is what is needed for the fellows to learn. But we follow, and I agree that transarticular wire is needed most often in an unstable. I've stopped putting a transarticular wire, but if I have a question about the stability, then there is no harm. and I have seen Dr. Johari. I learned from him. But off late, when I discussed with Dr. Johari recently, and he said I have stopped putting wires in, and we must inquire with him why he changed his practice. So this child, although the radiologic sign of AVN was doing well, she had full range of motion. Acetabular index has almost normalized. Yeah, go ahead, Kunal.
So
And this is
we continued the follow-up till 10 years of age to rule out any acetabular dysplasia. So we came out with the AI was 25 degrees at 10 years of age.
so now, Sandip, if you look at this X-ray at 10 years chronologic age and 7-year post-op, you see some subcapital coxa valga and bit of uncoverage, right?
Yeah.
Would you do something at this point? Or she is a girl and thyroid is still open. Would you do anything? She has a little bit of coxa magna also, but she has been having full range of motion, no problem whatsoever. Would you do anything at this point?
Well, it's difficult to say, but I mean, we still have, I believe insufficient evidence, but some surgeons may advocate a medial screw,
Yeah.
proximal femur medial epiphysiotosis screw. I have no experience with that. I really can't comment
We
for
we will share one of this case, but this age is bit advanced for a
yeah,
female.
10,
Oh,
10 female.
yeah,
Yeah. So no, I'm
10.
talking, as you're following up, maybe at a, age of about 7, 8, you find that, the child is developing coxa valga or caput valgum, more
Yeah,
precisely.
capital.
Then probably, you may think at that point of time. Uh, because now what you are seeing is a bit of an uncovering
Yeah,
uh, because of the coxa magna, it's coxa valga plus magna, I guess. So there is a bit of an uncovering, but
but since they
I,
have full range of motion,
yeah,
no
I
signs
would
of
leave.
instability will observe. Yeah,
Yeah, yeah, yeah.
Kunal, can you go a slide back?
Yes, sir.
So now at 6 years, if you can see APX, 6 years it looks okay. There is no uh, caput valgum at this point, you know, but because of AVN, but then you come and go back to the next slide, and then
I
even
agree.
at the
So
age
that's
of,
an age, 9 to 10, you can see that there is a sudden,
yeah,
increase in that 1 year between the 9-year-old X-ray and the 10-year-old X-ray.
exactly.
There is a sudden increase in the coxa. And I have also observed this phenomenon, and it just emphasizes the importance of observation. Though I'm not sure whether,
Yeah, so
any
we have
filter
some
at this point will help.
comparison X-ray. So what is important for everyone is we have to follow these children every annually because the game is not yet over. And they have secondary acetabular ossification centers also, which gets ossified near maturity. So you need to follow all of them in an hip clinic till they turn mature. And then ideally we should have a hip preservation, a transition clinic where we can shift them to adult practice. Let's move ahead, Kunal.
So at 12 years, we followed the patient and did a clinical examination. This was the X-rays showing coxa valga and magna, and with the acetabular index was completely identical.
It's not identical, it's a dysplastic hip, Kunal. Now, Sandeep, at this point, I talked to family that this child might need some hip preservation surgery because hip is not, the acetabulum is not coming down as it is expected. Her triradial cartilage is fused, so she is almost a mature child. But the family says that there is no problem. She is participating in sports and all the activities, and she had full range of motion. So it was difficult for me to convince them. And these are her range of motion, at that point at 12 years. So we inform them if she starts having experiencing pain and let us know in advance. Yeah, let's go on.
I completely agree with you, Molin, that in our setup, if the child has no symptoms, it is extremely difficult to, convince the
Yeah,
parents for a hip preservation surgery when they are asymptomatic. However, having said that, this kid, in young adulthood or sometime in adulthood, she is going to have problems. So
exactly.
that has to be clearly discussed
We
with
are
the
still
parents.
following her.
Yeah,
The other issue is what I've seen. If they are not symptomatic, like we cannot make a, ch- uh, a normal child better from parents' perspective. I'm talking.
absolutely,
And
absolutely. I
then
agree.
you need to do a varus and establish. So the child which was just having pain on prolonged walking would end up into lurch and shortening, which is very difficult to, in order to preserve that hip.
I
Let's see
completely
what
agree.
happens. Yeah, let's see what happens next. Kunal?
At 16 years, we again, yeah, followed the patient, and that was recently. At 13 years follow-up, we see that the hip has gone into coxa valga, and
So,
the problem is still dysplastic.
so at 16, like as Prasad said, sometimes that they can develop foveal arthritis, but when she's
Phobia is
asymptomatic,
abutting directly into it's coming in directly
exactly
into the
right.
weight bearing zone.
Yeah, exactly. So that has
Interestingly,
happened in
just
a
look at
kid.
the other side as well.
Uh,
You show the
yeah,
same thing to a hip preservation surgeon, and they will
so
say
they
that
will they will operate on both the
yeah,
sides.
yeah, yeah, yeah.
But show the clinical picture, Kunal. So she just came yesterday or day before yesterday. She still have full range of motion and she doesn't have any pain in the hip. So every couple of years we are following her,
Hmm.
and this is the time where I will now refer her to an adult hip surgeon. But she has been doing well. Now this case shows that even a child coming at 3 years, and if it is stable on reduction, one can probably avoid hip procedure, and that's what we have observed. So we check the stability. It's not a rule that we will do the osteotomy. There are papers that doing over coverage can lead to earlier cam impingement, and doing salters can predispose the posterior wall deficits. So we are judicial. So let's
So the
move on to the
hypothetical question to be asked here is, should we have added a femoral shortening in the first instance? But
yeah. I would always
difficult to say,
add
if it's all on the intraoperative feel, if your hip is going in easily without you having to apply too much force or traction, then I don't think
so
still
that
there is any role
see
for.
it reduced, it jumped in, so and
Yeah.
I didn't require much force, so we avoided it. Okay, let's discuss another case. Kunal, let's move ahead.
So
So yeah, we will share these papers now. Uh, yeah, Vaibhav.
Yes, good morning, everyone. So let's talk about case two. It's a 5-year-old female born at full term with C-section, breech presentation, presented with abnormal gait. So we clinically examined and found out the gait to be Trendelenburg and short limb gait mixed. And her left lower limb was shorter than the right. So this was the X-ray we classified and ISDI 4 and Tonus 3.
Yeah, so just go back.
Yeah.
And in this case was the X-ray is kind of identical, but what was chronologic age? 5 years?
Yes, sir, 5 years.
Yeah. So this is what happens that if there is not very high riding dislocation, many a times the family miss and the pediatricians also miss, and they reach an orthopedic surgeon at the age of 4 years, and by the time they reach to us, they are quite old. And here
The
we can see
acetabulum is pretty shallow, especially the
pretty
anterior.
shallow, yes, because this has gradually moved out. Ma'am, you are back?
Yeah, I'm there. Yeah.
Okay. So here, certainly, we would need established coverage and the femoral procedure, and that's what we needed. Yeah, go ahead.
Yeah.
So we did a subtle femoral shortening and a few degrees of varus and degas acetabular plastic. Now the question is, Sandeep, you perform Degas in all the cases, or you have some choice of between Salter and
It's a
Dega?
slight variant of Dega. I do the San Diego variety, but
Okay.
I do acetabuloplasty is generally my preferred option, especially in this type where it is kind of a sliding kind of a,
Yeah,
dislocation,
slopey.
not the
Yeah,
jumping one. Yeah.
and the coverage you need is quite a bit more. Ma'am, you have a preference, or you choose your established procedure based on the established
Yeah, I
morphology?
think if they are like, if I'm forced to do it in less than maybe 24
Month.
months, then I would prefer the Salter, because to split that outer table in Dega is a little bit more challenging in when the, especially if the child is very small. If the
Okay.
child is bigger and older than 24, then I have absolutely no problem doing Dega. This is my procedure of choice. Anytime I can do it. If I feel it's too thin, the wall, and I can't do it, I'll do Salters.
So in Salter, in Sikhi's unit, they avoid it before 18 months.
Yeah, before
The
18
reason
months,
being,
definitely don't
yeah,
do any kind of.
two two things that establish a huge remodeling potential, and second, if you do in very young children, in Salters also sometimes both the tables will separate out, in very young children. That can happen if you try to do with gigli wire. So the prerequisite, the child's age should be more than 18 months. And another thing is, if you need a more coverage, more than 20-25 degrees, then Salter's upper limit is around 20-25 degrees. And so more correction you need, you do go an estabuloplasty rather than design. And we have found that you need to be very critical while putting your bone grafts. When you want more anterior coverage, you put more graft in front than on the back, and not in the center. While in Salter, it gives a natural anterolateral coverage because you are turning the hip in. So this surgery looks okay at this point, Sandeep?
Yeah, I mean the lateral edge of the, yeah, fine.
Yeah. So we did around 2 centimeter shortening. Ma'am, you have any concerns in this on this post-op X-ray?
I don't
It
know.
looks okay.
This child is a 4-year-old child.
Yeah,
I would have
5-year-old
actually
to
added a
start with.
little bit varus as well. I think that's all I can say.
Yeah. So then
My
I would yeah. When you put a straight plate
because
and you are
if
giving 5-10 degrees of bias because of femoral
yeah,
flare.
some varus would be advisable, because
Okay.
otherwise you will be worrying about the stability of when they start to walk. Uh, or soon after that, if there is some growth disturbance, again you will land up in trouble. The hip
Okay.
will start to go. But it's nicely deeply seated. At the moment, there is no concern. But I would have just as usual, I would have
A
added
little
a
bit
little
more bias.
varus.
Yeah. Yeah. Vaibhav, let's move and show what has happened further.
We followed this patient at 12 months after 12 months of surgery, and she was doing fine. And we went
Um,
ahead. Sorry.
just this 12 months of surgery, the Establer index seems to have increased a bit. That's all I would like to say
So this is
compared to the.
Sandeep. Have you observed this? Sometimes what I see is the established index, which is immediate post-operatively, which we have improved. Sometimes it goes back. This might be because, as ma'am said, that we should add
See,
some degree
whenever
of
you see
bias
Establer index increasing, it indicates there's some hip is not very
instability.
deeply seated and there's an instability there. It could also be, of course, that you have some kind of a growth disturbance in the acetabulum itself. But you should also consider that your hip might be a little bit unstable and it's not very deeply seated. Here it looks on the X-ray quite well seated. It's
Yeah,
slightly, the Shenton line is in fact slightly over reduced. But
yeah,
this is definitely Establer index is increased.
yeah. So sometimes I have seen, I have followed them, and then near maturity again, the SIR index improves. So that because of secondary established central ossification.
Ossification, yeah.
But I was a bit skeptical with this, and we followed the family. And in very rare instance, I've done a Degas estabuloplasty for second time, in few cases. So let's see. Would you think that uh, any other thing than this? We have been always looking for hip maturity, established development, hip femoral development. But we have been following this child every annually, and for 2 years child was missed, and now they came to us at 10 years. Yeah, Vaibhav,
Yeah.
a 5-year follow-up.
So they presented to us at 10 years of age with again gait problems, lurching to the opposite side while walking. We
So
examined this patient. Yes, sir.
yeah, so this is what happened. It was a very strange complaint. The father says the child is moving, doing everything fine, but she's lurching on the opposite side. We usually see they lurch on that side because of the short abductors are sometimes shortening. And when we placed the child on couch, it was really long, lengthen the limb. And he was right. And so, yeah, Vaibhav, go ahead.
Yeah. So clinically, hip range of motions were normal, but we had ipsilateral lengthening of the operated side. So we went ahead for a scanogram and we found out to be ipsilateral femur longer by 3 centimeters.
So, Sandip, have you observed lengthening of the limb even after doing a couple of centimeter femoral shortening?
No, never. This is a freak case. I mean,
Yeah, so this is a very rare observation. Ma'am, your experience with, we usually assess the shortening and hip development, but this child ended up into lengthening of 3 centimeters. Yeah, Vrishra. Anyway, so we tried to search the literature and Vaibhav, show what we have found in.
Yeah, so we found literature. This was a study done in Seoul. They found 101 cases similar to us, but the lengthening of more than 10 mm in 44% of the cases and more than 15 in 23%, and none was more than 25 mm. So they concluded the risk factors to be early surgery between 2 to 4 years of age, and in patients with femoral osteotomy are prone to develop this overgrowth of the ipsilateral side.
Yeah.
Again,
101 cases of DDH operated and lengthening in how many?
sir, all these were the patients of lengthening. They found.
101
They,
lengthening.
yeah. So they had a series of around 500 cases, and out of them, they probably found 101 children with some form of limb lengthening. While in 56% of patients, they had lengthening less than a centimeter, 44% had more than 10 millimeter, and in 23, 1/4 of them had more than 1.5 centimeters, which required some form of treatment. The highest was 25 millimeters. So we were surprised that we never look at the limb overgrowth, and there's a huge series existing. Then there are a few more papers, yeah.
Yeah, again, this was study done in China to find out the risk factors. They observed 52 children who underwent both acetabular and the femoral osteotomy, and they also found out the younger age to be a risk factor for overgrowth.
So we seldom see a clinically significant overgrowth, but this girl presented right for that. She doesn't have any issue at the hip point. She has full range of motion. And so we ended up doing epiphysiodesis. And unfortunately, she presented at 10 years. So we did ipsilateral, yeah, show that.
So we did a ipsilateral distal femoral epiphysiodesis, and we followed up regularly till the correction, and this was the final length we got. So, and these are the final clinical images. Her gait is absolutely fine now, and she's doing well. Yeah.
So one,
Maybe she came in time.
yeah, that's right. Otherwise, we would require
The
some form of
lengthening.
lengthening, which is risky when the hip joint is not normal. And so this limb
There was a
length
little lengthening of the normal side.
yeah, yeah, then yeah, that would be great. That would be easier. So the message is we must look at the limb lengths also. Occasionally, you might find clinically significant discrepancy, and you can easily treat with growth modulation. Again, her acetabulum is not looking great. There's some dysplasia is there, but she's skeletally mature. What single advice I give to this family is that do not put on a lot of weight, because I have seen obese obese children having more significant hip symptoms than a thin and lean child. Okay, let's move on to
If
the
I just say, I think as a rule, we should do scanograms once in a while, not just for the limb lengthening, but sometimes also for the valgus, which also happens in this, and
yeah.
sometimes changes in the opposite limb, which can
Oh,
start to get uncovered if the limb is shorter for
yeah,
all of
that's
these
a
reasons.
very important message. Yes, Vaibhav, your last slide, can you summarize?
Yeah. So again, limb lengthening is uncommon, but it is observed. And post DDH surgeries, it should be monitored along with acidular dysplasia. And this case gives us importance of tailored surveillance and timely intervention in children undergoing similar surgical procedures.
It's an interesting case report, Sandip. We are writing this up and we will send it for pre-submission review to you and Risha ma'am because 3 centimeter lengthening has not been reported. Okay, let's move on to the next case.
So in this case, a 4-year-old female, full term, born by C-section and breech presentation, presented to us with a waddling gait, and there was increased lumbar lordosis with anterior pelvic obliquity while walking. The parents were concerned about that. Clinically, we examined and we found out the right limb to be shorter than the left and rest the gait.
So let's go back to history page. So Sandeep, when go back, yeah.
Sorry.
So just play the video for the fellows. If a child comes with this, we know that this prominent tummy, exaggerated lordosis, prominent buttock that signifies bilateral DDH. What other causes can give you a similar picture? If you want to tell your fellows that you think this possibilities when you see such gait.
So binding gait is, indicates any, hip abductor lever arm,
Abdominal weakness, yes.
problem. So it can extend right from a neurological problem, okay? Involvement of the hip abductors. It can involve proximal myopathy.
Yes.
Even because of, sometimes the severely vitamin D deficient children can walk with that. So you
Very
have to think right from the, the nerves down to the muscles and then coming to the bones. In bones, you can have, coxa you can have an overriding greater trochanter for some reason. If you have a coxa breva and overriding greater trochanter, even that can give rise to this type of a picture. So developmental coxa vara, post-septic scenarios, or cases where the hip joint is either dislocated or the femoral head is destroyed. Though femoral head destruction, septic bilateral, you wouldn't think so commonly. It is more commonly unilateral, but has to be kept in mind. So think from the nerves, what can affect the nerves, what can affect the muscles, what can affect the, the greater trochanteric overriding, what can affect the femoral neck, coxa vara or pseudarthrosis of the femoral neck, or hip dislocation or destruction of the femoral nerve. All these things have to be thought of in the DDs.
such a wonderfully narrated, Sandeep. These all are the causes. I like to add, we have seen some nail patella syndrome with patella out, and they have external or retroverted hips. I mean, the GT is going back, a lot of anteverted hips with tibial extortion, and there also you can see the same waddling pattern. Now, typically, these children have an identical abductor spread, so many times pediatricians fail to diagnose them. But when we see breach, we should risk factors. We should get the scans done earlier. But this patient presented at 4 years, and let's show the X-ray. Yeah. So now, in this is a very high riding DDHs on both sides. So Sandeep, what is your protocol of dealing? Do you treat both the hips in one go, or you stage them? And if you stage them, and but what interval you do the second case, second
So,
side?
does this patient also have a ligament laxity?
No, it's a routine child. No laxity.
So, what I generally do for these kids is do one hip at a time, never do two hips at a time. And as I said, we routine. So surgery most likely is going to be a complete full Monty procedure. So
Yes.
it's the open reduction. It consists of complete soft tissue release, medial as well as anterior anterior soft tissue release. It will consist of a femoral shortening with derotation. It will consist of a pelvic osteotomy, and I would also, fix the put in a transarticular K wire. So that would be done one stage or one side. The second stage I would take up at 4 weeks. So at 4 weeks, what I would do is remove the existing hip spica, operate the other side, complete the procedure on the other side, then return to the first operated side, remove the K wire, and then again put a hip spica. The
Right.
second hip spica would again be a bilateral hip spica extending, to below the knees on both sides. And
Right.
then, 4 weeks after that, again come back in the OR, change this second hip spica, at which time I would apply a 1.5 hip spica, with the full spica applied to the side which was operated second. And the side which was operated first, I would apply
Half
a
spike.
spica ending above the knee.
Okay. So, ma'am, do you follow the similar protocol, or you stage it with distant, or how do you do that? Risha, ma'am? Okay. So I think ma'am is busy. So, Sandeep, I used to do at 6 monthly interval, do the first side, let the child has mobility on that side, and then come back 3 months later once they are off of any orthosis. And then I heard that we started doing in conjunction, as you told, that a 1 month interval, so that the time is 3 months in spica. And again, I found that they turn very weak. They're very porotic, very weak. It takes very long time to. This is my personal observation. So now I've reverted back to again 4 to 6 months interval. Of course, they have to spend 2 spells in spica, but doing at 1 month interval or 15 days interval, and prolonging spica for 3 months, so making them very weak. And some of them had also developed
More than weakness,
pathological
stiffness is a problem.
stiffness.
But it does eventually come back, but I agree. I mean, the recovery
Yeah,
phase is
their their bone mineral density also reduced. I had a couple of instances where they fractured their distal metaphysis. So now I've reverted back to my original, because I never saw a patch fracture, or the rehab was not that cranky. But these are the approaches. There we have few surgeons who are doing similar case in one go also, but then it's a huge surgical time, and I always have doubted that how would you position the opposite hip? You are relying on the wire to keep that in, but this is fair practice. You do it sequentially in a month stage, and we'll inquire Dr. Risha Madhuri if she joins back. I saw a lot of senior people in the participant group. If you have a query or question or comment you want to do, just raise your hand. Yeah, so Vaibhav, go ahead and show what we have done.
So we did the same thing. We operated the right side first, and we followed the standard protocol of giving hip spica for 1.5 to 2 months, and then hip abduction brace for 1 month. Then we did the contralateral side also after 5 months.
So here, Sandip, I have placed a temporary wire, and what we do is this wire is turned posteriorly. So in a spica, you don't need to remove spica, but you make a nice small window, and you can pull that wire from there.
But
You
you
know?
keep the end outside?
No. It's inside the skin.
Okay.
It is beneath the skin and above the fascia. So you put a small nick, and you can feel percutaneously the tip of wire, and then so you don't need to change the spica, for removal.
Knowledge, can I
Okay.
just make a small comment on
Yeah.
this? See, I'm looking at your x-rays and I see the amount of abduction you're putting for you to feel comfortable about the hip stability, right? And if you had
It's
just added a varus, you could have been in neutral position without even having to put the hip in so much abduction. So actually, post-operatively, it should be such in an older child like 4-year-old that your hip is stable and looks okay. If even you could put spica in just about 10-15 degree abduction. This is quite a lot of abduction for you to feel comfortable.
so this is, ma'am, this is not the abduction required for stability. This was the ease of spica, the taking perennial care. If we keep it in only just 10 degrees of abduction, 10 to 15 degrees, and then we put a spica, then the perineal area care becomes a bit problematic. So this hips
It
were
will be
stable.
like 30-degree abduction between the two.
Yeah. So I think this
So
is around 30 to 40 degree of abduction, don't you think? And this was just for the ease of better care, and they were stable in neutral after doing acetabular and femoral procedure. On the left side, uh, I placed a wire for a month, and then we removed it through the spica window. So let's move on, Vaibhav, and show.
Yeah, so this is the 1 year follow of both sides. On the right side, the physis ossification is appears to be less than the left, and then we followed her up on at 1.5 years post surgery. So she's 6 now. Then we did an implant removal, and she presented to us 1 month after the implant removal with this.
So this Sandip, she fell in the school on the day one. So I usually ask them to remain sort of confined to bed after implant for 2 weeks, and then in-house mobilization, and then go to school. And in the first day of school, she fell down. Someone bumped her in, and now she has sustained this fracture. So how would you treat it? She is now maybe 6, 7 years old.
I would probably replate it.
Okay, ma'am.
I think I would fix it, leaving it in a little varus now because it's well contained. And since I'm going back for surgery, I'll repeat the acetabloplasty because definitely the acetabulum looked dysplastic before.
Now, I mean, I repeat acetabular my decisions are more mainly clinical. Now, this girl had full range of motion. She was not having significant lurch, and if we see the tri-radiate and the teardrop is also coming narrow. So, anyways, but how would you fix? You would put a plate again, ma'am, in the femur.
I think a plate should be okay. I mean, depends if you're just planning to do this. I would not. You're planning to fix it in the same position as it is, or you want it a little varus?
I think I would just leave it like this. I don't think it is the hip is in valgus. So at that point, I thought so. So let's see what we have done and see what happens to this case in long run.
Yeah.
Yeah,
So we went ahead with a tense nailing in the femur, and we got a good.
And ma'am, we have done a little bit of varus. You see,
Yeah.
there is some.
So
I don't know
you
what the
didn't have any
purpose.
problem negotiating the canal here.
Yeah. So it is probably because it healed this way. I could not put the nail right up to the neck. No, but there is certain degree of bias. Yeah, go ahead with the. So
So-
1 year, yeah, it looks now, ma'am, it looks okay. I have not done virus. I have not done acetabular. You think
No,
it
I
is
think you've done varus. You should not say I've not done varus. You've done varus.
You're done.
okay?
Yeah.
I have inadvertently done virus, and that has lead to a better.
I think that might have actually varus might have improved if she was still within the correct age. It could have improved your acetabulum also. I don't know. I don't see the acetabulum on this X-ray to be able to comment.
The X-ray you
It would
see,
have.
but
Putting the hip in varus does improve the acetabulum because the containment gets better
I
and the
agree with.
acetabulum also improves.
Yeah. So there is a minimum 2 degree or 5 degree of virus has improved this.
We don't
Let's
see the acetabulum on these
So
X-ray.
Maulin,
There.
had you kept a plate standby here? The reason I'm asking
Yeah,
is, did you have any concerns that the screw holes may not allow that
yeah.
nail to be negotiated? You might
So,
have some
so
screw
I wanted to drive this message, like I had plates, but I've done a few post implant removal fractures fixed with wires. It's very easy to put two tens, and we have always been taught that it's very difficult to negotiate, but it is not that difficult. I'll tell you, because the screw goes into one particular region of the medullary canal, so you can put your nails through the other part. So you always keep the plate standby, but it's not that difficult to negotiate nails.
I think,
Okay, so let's
Marlon, we
move on.
still need to be careful about the lack of anterior coverage Because in the
Yes,
lateral
ma'am.
view that you're showing, maybe you can do a true lateral view, but what
Yeah.
is seen here, you see that the anterior is part is not very well covered. Like I don't know whether she's old enough
Yes.
to draw those lines, but if she
She
is,
she is yeah, I think she's 7 years old now. So, but we are anyways following them, and we know that this is not a perfect hip, and she
I
might
think
need
for
something.
ideally for students' sake, the thing that they should be palpating at each visit is the anterior lump sign and see in how much flexion the lump disappears. So if you have an anterior lump sign, that means that you have a hip which is uncovered, and that they have to flex it to see if it disappears, or
Right,
internal rotation to see if it disappears. So both of those could be the cause. There could be an
right.
anteversion causing it to be create an anterior lump sign, or there could be a excessive what do you
Capture the
call it,
thickness.
lack of coverage. Uh,
Right, right. So let's move on, Vaibhav, and
So
what
again, we
happened?
did the implant removal and we followed her at 10 years.
Now,
Yeah.
So now, ma'am, this is 10 years, and acetabular coverage, as you can see on AP as well as lateral view, is not that bad, right? But now she is 10. Let's move on to the other follow-up, 12 years and 16 years. So now,
I think looking at the growth plate,
yeah,
it is clear that we are having the growth plate is being dragged laterally,
yes,
suggesting a growth disturbance here. And
right,
that is reflecting in the way the hip also is behaving. You're getting
yes,
little more uncovering laterally. I'm not
right,
seeing the lateral view to be able to cover, say, and possibly anteriorly also. I think we need to actually see the true lateral view to cover about anteriorly. Um,
right. She,
Shenton line slightly broken. I mean, there is some shift in the Shenton line as compared to before. Because before
right.
you had an over-reduced Shenton line, now your Shenton line also looks little higher on the
So
upper
the
side.
question is, I agree with you. Now, again, this child is asymptomatic. She is not, I had to call her to see her final follow-up. They didn't come because she is asymptomatic. She is now getting into the studying years of 11th grade. But as we can, yeah, she
She's
show her
15.
clinical picture.
How old is
She's
she now?
16 years. She's 16 years old now. She can squat. She can sit cross-legged. There is no limb length discrepancy. A subtle lurch we can, if we look at her very carefully. But she doesn't complain of any problem or pain at the hip. Now going back to the X-ray, going back, go back one more slide.
So,
So again,
just
in this case, yeah, here Sandeep, at 7.5 years, we don't see subcapital coxa valga or caput valgus, but in
exactly, that point
subsequent
we
X,
brought up in case number one. It typically
yeah, the same,
happens between the age of 8 to 10 that
exactly,
things seem to be okay, and then between about 9, 10 years. Now the
yeah,
question is, when you first spot it at 10 years, that go to the 10-year-old X-ray.
10-year X-ray,
Yeah.
just 10 years,
So
Weber.
here is where it has started developing. The question I
Yeah.
would like to ask you as well as Madam, at this stage, at the 10-year-old, would you consider putting in a medial screw, proximal femur,
No,
medial
this
screw?
stage I would have done it because medially there's very little thing to reach out to. I would have done a varus osteotomy. In fact, I know I'm harping on this a little bit, but I think a varus osteotomy
No, no, we got
to
that
either
point,
to
ma'am,
avoid
because
an effect of growth disturbance or to take care of growth disturbance while you still can. Because at this stage now you will also be having to consider other options like a periacetabular or something to provide adequate coverage. Because soon she'll develop instability and labral issues. They will be there with this much uncovering. Most likely they're there. We don't have two lateral views, but there will definitely be anterior issues here. And Indian patients don't tend to notice till it becomes quite extreme. But there are
right,
issues here which possibly we need like a adolescent hip kind of a
right.
intervention. Yeah.
So now here, Sandeep, I'll show you one more case. Now she was 10, and I observed that she has some subcapital coxa valga, but her physes were thinning out, so she didn't have much growth remaining. For the growth modulation around knee, it is said that you should have at least 1 year of growth. And for Ian Tarot's paper for the proximal femur, you need to have at least couple of years growth remaining for having some effect. So here I thought we missed the boat of doing that. And from 7.5 years, and this is at 16 years, the same hip. As ma'am very rightly said, there's a lot of uncoverage on the lateral side. We do not have a true lateral view, but there is some lateral growth disturbance. Now let's show one more case. Vaibhav, yeah, you can describe that paper. All the fellows should read, and this. Yes,
So,
Vaibhav. Yeah.
so this study of Jan Tarot, the main cause of this subcapital valgus is due to the lateral growth disturbance of the physis, capital physis, and they reviewed 13 hips and did medial epiphysidesis in cases, and most of them improved with a more oblique geometry of the capital epiphysis later on, which was previously horizontal.
Yeah. So let's show the similar case we did. Yeah.
Yeah. So this was again similar case of a 4-year old treated with for bilateral dysplasia of hip, and we again treated it with full Monty procedures bilaterally. So she was followed up at 6.5 years of age, and
So
as
now look at this, Sandip. This was a boy actually, and at 6.5 years, the frog lateral axis look okay, but the child has subtle subcapital coxa valga and reversal of the physis. And now I'll take this from ma'am that we must add a varus, and so we did this medial epiphysiodesis screw. Yeah, Weber, go ahead. So that was done at 7 years, and there is substantial growth is remaining. 7.5, yes. And at 10 years now, you see the femoral head has become better. The growth plates have become horizontalized, and the screw has moved proximal to the physis now. And we did exchange screws here. Earlier we placed 4 mm, and now we have placed, I think, 6.5 mm screw. The child has grown. Yeah. At 12 years, this is the picture. And this, I think, this is the final X-ray. Weber.
sir, last fellow was at 13 years.
So, ma'am, your comments on this? So you
Yeah,
can see that we
what I
put.
would say is when you put that, I think for such a severe case, I would have done the varus osteotomy and then at the time of implant removal or at the same time added the medial epiphysiodesis screw. When you have got such severe valgus, it would not be advisable to rely on a medial screw epiphysiodesis to correct the whole thing. So varus is
Yeah,
important here. It has to be done
yeah,
it, and
yeah,
and you add the screw to prevent recurrence, not to correct it, but to prevent a recurrence. Then it works much more effectively because you
right,
get your correction and you prevent a recurrence.
right. So as this was
I
a very
think
young child, we thought that this would be we do this medial epiphysiodesis, but initial varus is the key, I think. Yeah, Sandeep, your comments?
Yeah, I completely agree with madam. Slight virus would have further, given coverage to the femoral head.
Yeah.
And
So when
the
I have
the other
always
piece
thought that
is the technical difficulty is, that medial epiphysis where you need to place the screw that is too thinned out in these kids.
yeah,
And the arthrogram really helps,
yeah,
because
yeah,
the amount of cartilage.
we have
Uh,
to do an arthrogram and see the medial margin. That's right. Yeah.
so
So
on
it's a
X-ray, it
it's
may
a
look like your joint, your screw is penetrating into the joint, but actually on the arthrogram makes it clear that you
yeah,
have a
yeah.
short of your cartilage.
Fine. Let's move on. Yeah. So these are the papers to see for the fellows, and we'll share the PDFs. But as ma'am said, there are people of doing varus osteotomy for this also. Yeah, let's move on to the last case of the day, Kunal.
Here to present the last case, it's a known case of Kabuki syndrome. And we can hereby see that there is exaggerated lumbar lordosis, waddling gait, as well as there is a disc coordination.
So this patient was residing in Canada, and there a thorough workup, genetic workup, and everything was done, and patient was diagnosed as a Kabuki syndrome. So bilateral DDH with dysmorphic face and hyperlaxity, there are certain syndromes which we must keep in mind, and Kabuki syndrome is a rare affection, but it can be there. Yeah. Um,
For all the fellows, I would like to suggest the paper to study that explains what is Kabuki syndrome, and it is like the genes involved are KMT2D and KDM6A. The syndrome is usually diagnosed by the facial features, but there are other abnormalities like cardiac, renal, genitouterine, endocrine, neurologic, and also the hypotonia and the skeletal affections are also present. The other paper is about that the diagnosis about the hip dislocations and can be done by a USG and X-rays, and treatment can be managed by conservative as well as surgical methods. But conservative is reserved for younger patients, and the surgical methods are for use for the older patient. The skeletal abnormalities in the Kabuki syndrome are scoliosis, vertebral malformations, and brachydactyly, clinodactyly, hip and patellar dislocations that usually occur. The treatment options for this patients that require are pelvic osteotomy, femoral osteotomy with open reductions that are reserved for older patients. As our case is 4 years old, we would try that. But the persistent acetabular dysplasia is very common, and the resubluxation and dislocation risks are very high, as explained in this paper of David Camp.
Yeah, so I would like to know from Risha ma'am her experience and how you deal the hyperlaxity DDH differently than the routine DDHs, ma'am.
I think in hyperlaxity DDH, our main aim is to totally go only for bony stability. So open reduction by itself is never of any use because you cannot restore stability with this. So ephemeral osteotomy and a varus osteotomy here is a must. So derotation plus varus is a must here, as well as acetabular. So in a hyperlax hip, you should actually get your hip totally stable at the end of the surgery. There's no way you can expect it to become stable later. And you also have to be aware that if you overdo any particular part, like if you try to do it reefing anteriorly of the capsule, you're likely to push the head out posteriorly. And then
Right.
at the end of it, you should watch for persistent dysplasia. Why they say that there is a persistent acetabular dysplasia is you did not seat your femoral head nice and deep. So I think my answer here is varus derotation plus acetabular. Just consider it straight away. Do not think that you can restore any kind of stability by doing capsulorrhaphy.
Just capsulorrhaphy, yeah.
It's not going to happen later also. It has to be
Right.
on the table.
Right. So, yeah, Kunal, take us through the case.
Well, the investigations done for the case was X-rays, ultrasound abdomen and pelvis, and 2D echo. X-rays revealed bilateral hip dislocations, which were very high riding, and we saw the non-ossifying capital femoral epiphysis, and the USG abdomen showed polycystic kidney disease, and the 2D echo also was done for cardiac anomalies.
So, preoperative fitness, everyone should look into this. Get 2D echo, get a ped nephro reference. This child underwent dialysis in infancy and he had electrolyte imbalance, but now it is settled, so it's okay for going in. Yeah, and show what we have done.
So what we planned was first we started with the left side with the anterolateral open reduction with Dagger's osteotomy, and we couldn't see the head on the X-rays and intraoperatively. So we did an axial MRI to see if the head was completely reduced, though the stability was checked intraoperatively. The hip spica was removed after 2 months, and
So, ma'am, do you do any the hip spica duration is the same, or you keep
I
it for
usually, because these patients come from very far for me,
yeah,
it's always 3 months. I just
three
straight away
months.
do
Okay,
3 months. Yeah.
3 months. Okay. Yeah, Kunal, move ahead.
After 6 months, we planned for the right side anterolateral open reduction and Degas osteotomy, for which again the hip spica was given for only 2 months. And
So, ma'am, as you say, this side, even though I had done the Dega, the hip was not looking deep seated. I have not done varus at that point. I should have done, but because it jumped in very well because it was hyperlex, and
Yeah.
uh, I did estabuloplasty so that it's a good anterior coverage. But I thought that I can get away without femoral procedure. And on right side, I was not happy, although clinically child was okay. And then I had to repeat the establish procedure as you said. Yeah, go ahead, Kunal, and show the X-rays.
I think I've had one patient like this long ago. I mean, I think somewhere very, very early. And like you said, it jumps in because they're very hyperlax, you can actually put them inside very
Yeah,
easily.
yeah,
And
but
because
still,
it's
yeah.
tight in that position, it stays in and it
Hmm.
feels like it's very stable also because of that.
Yeah. So at that point, I thought that it is so stable, I don't need to do anything. But still, I did the Degas because of the preceding paper showing high rates of resubluxation. But in about say about 6 months' time, there
AVN.
were AVN and the right hip was not developing well. So we did varus and derotation, and I had to repeat the Dega. So
I think
one
should
one
not
more,
think it's only AVN. It could also be ossifying because you never had ossification
yeah,
before.
yeah, yeah, yeah,
Could be
yeah.
an ossifying acetabulum, I mean, femoral head also.
So, ma'am, when you do DEGA in children where femoral shortening is not required, so you do not have a femoral shaft as a graft, do you take from the pelvis or you use some other bone graft?
I'll take from the ileum itself, but I'm just saying, in a 4-year-old, if you are able to, if you require an estabuloplasty, I'll just advise you just to be on the safe side, do the femoral shortening.
Okay,
Because all my avians, which I mean, I had in the initial stages a very high avian rate in patients where we went ahead without doing femoral shortening
okay,
in older children. It's like almost like a uh, the four out of a series of 12 avians were
mm-hmm.
all in patients who did not have
Femoral
femoral shock.
osteotomy
Yeah.
shortening. Okay,
So I think it, even if it feels okay, it goes in, but it will be a little tight. We don't realize it, but it will be a little tight. And these are the guys who get avian.
yeah, right, got it, ma'am. Okay, so now we have done this spica, we have done virus and DEGA again, and this child did okay. Yeah, can you show the final follow-up?
yes,
Yeah. Mm.
So, so the hips are okay, but he has certain lurch, of course, better than before. But yeah, thanks, Sandeep. Thanks for your
Hi,
help.
Sandip.
Yeah, yeah. You show the final follow-up. Now we have few slides only.
at 4 years, the child
He's 8 years old now. Go back to the X-ray.
8 years old, the child that 4 years follow-up, we saw that the X-ray was better than before, and the acceptable index is
So, ma'am,
also.
you are worried about this X-ray now? I mean, again, even after doing varus, the right hip is
I think it's a
little.
little coxa magna on that
Hmm, yeah.
thing.
And the
So,
physis line on the lateral view looks a little
yeah,
bit of slipped physis, but I hope that is okay. This must be
lateral
just
view.
in the
I
frog
wouldn't.
lateral view.
Yeah, I think it may be just an eccentrically placed
Hmm.
spices like we
Yeah.
usually see with some minor growth disturbances.
Yeah.
I would not consider it as a slip physis, but if you wanted to do your um,
MRI.
no, your medial screw
Hmm.
epiphysiodesis to make sure
I'm
it doesn't
just,
go out, that
yeah,
might be
I'm just observing this boy and will consider if it goes like that. But now
I think
this
one
time,
comment about the limp that you saw in the first follow-up that you were saying that he's
uh
walking funnily. I think just tell all your patients that the hip takes about 2 years to recover. So if
right,
they don't, they are seeing gait abnormality for up to 2 years, it is because the muscles take long time to recover normal strength. So some
right, right,
weakness is there and some limp is there for quite some time. Same
yeah,
as for femoral shaft fractures.
right. And some of them have a abnormal pelvic incidence, the placement of pelvic, and they, even though they mechanically they are fine, they have some lurch. That's what we see in skeletal dysplasias also. Anyways, but now this child mother complained that this child is doing habitual anterior dislocation of hip. Can you show that video on the left side, not on the right side? Play that video. So he can bring the hip out
And this is
voluntarily.
like an anterior lump sign
Anterior
even
coverage,
without
yeah,
bringing out.
yeah.
Yeah.
And he can put it back in. So
Yeah.
earlier he used to do very free. When he is angry, he will do this to
So
bring
I
the
think
attention of
this one is
family.
a pure indication for doing a derotation
Yeah,
because they don't try to do it with any kind of a soft tissue procedure. He requires a derotation purpose to
and should
rotate
we
it
do
post.
and might be she need an anterior coverage further, I think. I
Yeah,
don't
yeah.
know. So
But
yeah,
this is
so
actually basically a sublux. They go from posterior subluxation to anterior, anterior to posterior. So they need a very good bony stability. I think that is an issue for them.
yeah, yeah, yeah.
All the hyperlaxity children will do it. I've had
Yeah,
many do like this.
right. So mom says that this incidence of voluntarily bringing it out is reducing as the child is getting maturer. Earlier it was more, so I'm just sitting on it. They are not
But
keen on
even
getting.
then, it is even though he's doing this, he has a lump sign at all times. You just look at
Oh,
him. It doesn't completely disappear. Even when he's reduced position, he still has a lump sign. So he's antiverted and he's just exaggerating it to root by rotating.
right. Fine. So we are keeping this in mind, and this might need a X-ray wise looking okay. Hip might also need a derotation. So I think it's time to what time it is? Yeah, we have passed 24 minutes. So I think we will share these papers, and I would thank you everyone for being with us. Thank you, madam, for your time and valued opinion. I learned a few things today. Your final comment before we conclude this session.
I
Thank you,
think
ma'am.
important thing in a child who's more than 2 years old is that we should aim for stability on the table, and we should not hesitate to do all three. And we should not be shy about just because we read about it. We should not be shy about not doing a varus. I think it's quite fashionable to think that we can get the whole thing with just straight, just doing the derotation. But we have to remember that most of our children have some amount of growth disturbance. I hardly ever see children who have absolutely no growth disturbance. So it would be better to just do a little varus because we have seen even with the Parthis that these all straighten out. So you don't have
Yeah,
to worry about the varus being permanent and it's safer and seats the hip deeply. I think that's my
yeah,
message. And
yeah.
in the
So
hyperlaxity, bony procedures are absolutely essential.
right. So these are the long-term experience in the field, and we realize this is the 15, 16, 18 years follow-up now, ma'am, that they need to be followed up for long, and the story is not over once hips are in. And I now might teach my fellow that you learn hip preservation through your training time because that journey will keep on going. Thank you very much, everyone. Thanks, ma'am, for your time, and thanks, Sandeep, for being with us. So we conclude this meeting, and we'll meet next week with some other topic. Have a
Thank you,
great day.
Maulin. Very nice cases and enjoyed it.
Thank you, ma'am. Thanks for your time.